Hi. Good morning, everybody. It is March 14th, 2019, and I am here in Denville, New Jersey at the Hypertrophic Cardiomyopathy Association's headquarters to bring to you a good bit of news. We have a brand new HCMA recognized Center of Excellence joining our family. And during these next few minutes, you're going to get to meet the director and hear a little bit about the program. We remind you that there will be a question and answer period at the end of the interview. Please remember your question should be phrased in a more global fashion. We will not be able to give individual consults live on Facebook, but you're welcome to call the HCMA office, and we will be more than happy to answer your questions and forward any inquiries to our guest today. So without further ado, I welcome a longtime friend, Dr. Ferhaan Ahmad, with the University of Iowa. Good morning.
Well, good morning, Lisa. It's delightful to be here.
It's great to have you, and it's great to have Iowa on our map, finally.
Hey.
So I'm really excited about that. So we start most of these conversations with the questions. When did you first hear the terms hypertrophic cardiomyopathy?
Well, I have to think a little bit about that. I think I'll probably age myself a bit, but I went to medical school a little while ago, and at that time, HCM was recognized, but not very well recognized. You might say it's still not very well recognized, but certainly wasn't that back then. And so I heard a little bit about it in med school, but really when I became more exposed to it from a clinical standpoint was a little bit in internal medicine residency, and then certainly during cardiology fellowship. Seeing a few patients with HCM, and then also on the imaging side, when we were doing our imaging rotations, we would see echoes, particularly from patients who had suspected hypertrophic cardiomyopathy.
And what year was that?
So let's see, I graduated from med school in 1991.
Okay, so we're talking early 90s, not a lot of appreciation, but you knew what it was when you saw it, if it happened to pop up on your radar screen.
Right.
When did you really get interested in HCM?
So, well, let's see. So after all my clinical training, then I was kind of crazy. I went back to graduate school and went to Baylor College of Medicine in Houston, did a PhD in human genetics that focused on the cardiomyopathies, including hypertrophic cardiomyopathy. And then subsequently, I did actually postdoc as well, postdoctoral fellowship at Harvard and Harvard Hughes Medical Institute, which was focusing on mouse modeling of cardiomyopathy. So that's when I really sort of started eating and drinking and breathing cardiomyopathies, especially hypertrophic cardiomyopathy.
Okay, so that's a good 25 years-ish that you've had some interest here.
Right. Yeah. So yeah, if you think about after I graduated from high school, it was like 21 years of training before I got my first job.
Well, it's a lot of training required for understanding the human genome and how it impacts our heart. So we're really glad that you did do all that postdoc work and education. So tell us a little bit more about your background. So you went through your undergrad, you displayed an interest in genetics, you did that. And how else does that tie into what you're doing today?
So, well, all my background training really was focused on becoming a cardiovascular geneticist and really focused on cardiomyopathies and particular hypertrophic cardiomyopathy. And so, well, I actually didn't do a full undergraduate college degree because I'm from Montreal, and in Quebec, we do have a fast track system where you can do a shorter sort of undergraduate program and then go straight in, get admitted into medical school. So I went to med school at McGill and then stayed on there for internal medicine and general cardiology. And then really all my, that was of course more broadly focused, but then after that, it was all basically human and animal cardiovascular genetics and cardiomyopathy and heart failure genetics. So it really I had the opportunity to work with families and patients with hypertrophic cardiomyopathy, and then study a lot of the findings we glean from patients and families, and then go to model systems and work on trying to figure out some mechanisms of the disorder, and then go back hopefully to translate some of that back into our patients and families. So that was the next probably 10, 12 years. So I finished clinical training in most of my clinical training in 96, and then I finished my science training in late 2004, so 9 years, and that was all basically preparing me for what I'm doing now.
So a few years after that, you were living in Pittsburgh, correct? Mm-hmm. Why don't you tell us about your experience with HCM in Pittsburgh?
All right.
Where we met.
Yeah, that's right. So, so after I finished my postdoctoral fellowship at Harvard in Boston, I was actually being recruited by a number of different universities in both the United States and Canada, and chose to go to Pittsburgh. And there's a story behind that too, but we'll leave that for another time. So Dr. London, Barry London, recruited me there. He was the chief of cardiology in Pittsburgh. And I established my basic research lab there, and then at the same time established a clinical program in cardiovascular genetics. And then after about 2 to 3 years, we thought it would be appropriate to try to focus and have a specific center for hypertrophic cardiomyopathy. And that's when we got in touch with you and said, hey, we're interested in doing this. Can you give us some advice on what's the best way to establish a focused HCM center? And I guess the rest is history. I think you told one of my coordinators that about 80% of people who call never end up establishing a center, but we were one of the successful ones, and we over the next several years we grew quite nicely, and we went through the process of being certified as a center of excellence there.
Yeah.
So I don't know, am I the only one besides I guess Marty who's done it twice, right?
Yeah.
I'm probably the only other person who's done it twice.
Well, we actually have 3 people who have created programs twice.
Okay.
It would be Tufts and the satellite program at Morristown Medical Center. The team that used to be at Johns Hopkins, who is now moved out to San Francisco, so they've just done it twice. And you went from Pittsburgh to Iowa, so you've done it twice.
Right.
Which tells me the model works, or you wouldn't go through this twice.
That's right. That's right. Because you do get a little tortured by you guys just a little.
We have to keep you on your toes. That's our job. Remember, first and foremost, the HCMA is patient advocacy and ensuring patients have access to high quality health care. Mm-hmm. And that's why we call it a recognition and not an accreditation. We are here to say you have all of the skills, training, infrastructure, and support to treat the HCM patients the way we know at the HCMA patients want, need, and should be treated and cared for. And when you use the model that we've created, which is really a patient-driven model with the eye towards how academic medicine works and how clinical cardiology works, and we put it all together, you've seen how it works. You saw it in Pittsburgh, and now we're going to do it in Iowa. And as we progress with these programs, we learn more and we make ourselves better, stronger, and a more powerful voice for the HCM patients. So I've been thinking a lot about that lately because there's a lot of new programs knocking on our door now, way more than there ever has been. In 1 month, we had 5 inquiries. So that's saying that the model's working, and we're really happy to have it planted in Iowa. So tell us more about your team.
So over the past few years since I've been here, we've basically brought together a really, really cool team. First, we have some great support, and that's one of the reasons I came here. We have a great support system from the administration here, both on the clinical side and on the science side. So Dr. London is now here as well as Chief of Cardiology, and Chris Benson is the clinical director for cardiology. Jonathan Blumke is our administrator on the cardiology side. And then we have on the clinical heart and vascular center, which houses our actual clinic. Phil Horowitz is the medical director, and Kathy Pierce, the administrator. And they've all really been very, very supportive over the past couple of years, especially in terms of building the program and then working towards getting HCMA certification as well, or recognition, I should say.
Thank you.
But in terms of our own clinical team, besides myself, we have a number of other cardiology subspecialists. So Mahi Ashwath is our cardiac MRI and imaging person. We have a couple of great electrophysiologists, Steve Galen and Mike Giudice, and Mike's the director of our EP service. But he came to us from actually a private practice about an hour east of here, and he actually had a big HCM practice in his private group there. And
really?
Yeah, so he's had a history in HCM. Jim Rawson is our interventional cardiologist, and he's actually director of our cath lab as well. We also have other physicians who are not cardiologists, but we think are very important to have as members of our team. So, as you know, sleep disordered breathing is a major problem in HCM. So we actually have Kevin M., who is a sleep medicine specialist, and he works with us, and he also actually works with some of the other neuromuscular and cardiovascular genetic disorders as well. Jess Fideritz is our psychiatrist consultant. And then on the non-physician side, Katie Haltmeyer she was a great doctor of nursing practice student here in Iowa who basically rotated with us for about a year. We loved her so much that we hired her on staff, which is great because we're kind of almost overextended already with all the new referrals and new patients coming in. So it's great to have that extra bandwidth that Katie brings in. We currently have one genetic counselor. We did have two, but we lost one to industry just recently. But we do have Maggie Breeze. And actually, right after this, I'm supposed to go to this recruitment meeting just to look at an applicant who brought in last week.
Still growing. Still enhancing the program.
We're on the way. Yeah, hopefully we will be back up to having two counselors shortly. And probably, I should say, last but certainly not least, and probably in many ways the most important person is Becky Gutman. She's our nurse manager. She manages the program with me and keeps me on my toes, along with you, of course, and basically organizes all the intake and all patients and families coming in, making sure that they're going where they're supposed to go, having all the appointments they're supposed to have, and hopefully making it a relatively seamless and painless process.
That's a big team. You've got a big catchment area too. So where are patients coming to you from at this point? You're in Iowa. So for our Midwest folks, where is an easy commute?
So we are getting patients from, far and wide, but the majority are from Iowa, Western Illinois, some from Nebraska as well, and then southern Minnesota, Wisconsin, and a little bit of Missouri as well.
Okay.
So it's the majority of patients are from sort of our region within probably 6 hours drive, but we do have people flying in as well. So it's not just driving distance.
Yeah, it's kind of centrally located, and it's not so busy, and the airport is really civilized. You can get to the airport maybe 15-20 minutes before the flight and probably still make it in. And there's some beautiful new hotels in town. I was able to stay at one and enjoy that and see one of your amazing Iowa thunder and lightning storms. A little scary, but it's okay.
Well, I mentioned we couldn't arrange a tornado for you that day, but
I'm really glad about that, and let's just keep that in the plans. No tornadoes when Lisa's in town.
Let me just say we have not had a tornado in Iowa City since I've been here, and apparently the last one was many decades ago. So.
Okay, good to know. So I know you have some really interesting research projects, and many years ago, the HCMA used to use a tagline, there's no cure for HCM, but someday pigs might fly. And here we are again with the pigs involved. So why don't you tell us about the pigs in HCM?
Right. So as I mentioned, my background, I'm a human geneticist and I'm a mouse cardiologist. But since coming to Iowa, I've become a pig cardiologist as well. So we actually have, as you can imagine, we have sort of a certain selective advantage being in Iowa. We have a lot of pigs around. And so there's actually, out of another group at Iowa working on cystic fibrosis, there was a company established that actually will genetically engineer pigs for specific human disorders. And so we've been working with Myocardia, which is a biotech firm that is actually developing drugs for HCM, along with Exemplar Genetics, which is the company that constructs these pigs, and then us at the university. We've been studying some genetically engineered pig models that have human mutations that cause HCM. And we spent, pigs are much harder to work with than mice. But we've been diligently doing a lot of really interesting studies over the past getting 3.5 years now. And the pigs definitely have a hypertrophic cardiomyopathy picture. And we have been working on trying to image them and do very detailed tissue studies, very detailed molecular work on these pigs. But we've also started studying mavacamten, which is the drug that is currently in clinical trials as well, in these pigs. And we've given them acutely just one dose and then measured their blood pressure changes and the way their heart works right after that acute dose. And we can see a reversal of some of the abnormalities that we see in HCM just with one dose. And then we've also now been working on sort of longer term therapy, just as patients would be getting, and we're seeing some very interesting results there as well. So it's a very exciting time where we're able to work with human patients that are part of these clinical trials, but then also sort of delve in a little bit more deeply into what's happening at the heart level and the blood vessel level in these pigs.
That's fascinating. And you're also involved in the human clinical trial for mavacamten, correct?
I am. I have delegated the what we call the site PI role to a couple of my colleagues who are part of our heart failure group. And there's a reason for that, because I'm actually studying the pigs. The FDA does not want me involved in both the animal work and the human work. It would be considered a conflict of interest. So I am not directly involved in the clinical trials, but I'm there as a supportive person. And certainly a lot of our patients that are coming to our HCM center are candidates for the clinical trials.
Very good. So we're developing genetically modified pigs. We're giving them potential therapeutics. We're seeing some positive data so far, but we've got a ways to go. Mm-hmm. And then the big question is, does the human heart and the pig heart really respond the same way? And that's how much further out are the answers to those questions?
I think that a lot of the answers are going to be coming within the next year, 2 to 3 years, in pretty rapid succession. The one nice thing about pigs is that we can study them in ways that are similar to what we do in human patients. We can do catheterizations and put in these catheters and measure pressures in the heart. We can do very detailed imaging with MRI and echo, which we can do in mice, but it's just not quite the same, and you don't get the same details that we get in the pigs. And so we are seeing a lot of parallels between human patients and these pigs. They're not, I wouldn't say that they're necessarily 100% the same, but they're very much more similar than, say, the mice and people are.
Well, I think that's fabulous, and I thank all the pigs for their hard work, and they're helping us live better lives. So now we understand a little bit about your research focus, which is really interesting to an HCM geek like myself. But let's understand the logistics. If a patient wants to come see you, what's the process? How do they get involved? How do they make that first interaction to maybe transfer their care from a community-based cardiologist in Iowa to a true center? How does that work?
All right. So first off, we have many models. I don't necessarily want to take away patients from their own cardiologist. If they want to stay with their cardiologist, that's totally fine, and we will just see them serve as consultants and provide advice and feedback to their regular cardiologist in their community, and that would be fine. If the cardiologist and the patient prefer that they come here full time for their care, that is totally fine by us too. But we try to work with our patients and the referring cardiologists to make sure that everybody's on the same page, whatever the model they want to work with. And as we discussed, some people are coming far away, so they may prefer to have a local cardiologist too. Anyway, so basically the way to get in touch with us is, we have our sort of central phone number that's on our website.
And on your HCM directory listing.
And there as well. And so when they call, they will speak with a scheduler, and the scheduler will just get very basic contact information from them. And then they pass on all that information to Becky Gutman, who's, I mentioned, our nurse manager. She gets a hold of all the details and then calls the patient or the family and gets more information, and then tries to figure out, what's the best time and way for them to come with or without their family. And then she will work with the schedulers to get all their testing done, for example, echocardiograms or stress tests or cardiac MRI, and then visits with the different providers, including myself and genetic counseling and other providers potentially as well. We try to get it all done in one day if you can, have everybody come in, and because we know that people are coming far away, they have to travel, they have to take time off work. So we try to get everything done in 1 day or maximum of 1.5 days if necessary, so that they don't have to disrupt their lives and their work and their family schedules too much.
And the one thing we didn't discuss, and maybe should have talked about in the team aspect, your program is not a high volume surgical program. So you're referring your surgeries at this time to the Mayo Clinic. Is that correct?
That's right. So as you know, and we all know, the best outcomes are at high volume centers. So at this point, we don't have sufficient numbers of patients who need myectomies, so we would prefer that they, in most cases, they do go. The closest center here that's high volume would be the Mayo. So we have a very good relationship with the cardiologists there, including Steve Bauman and others. And so essentially, the Mayo Clinic doesn't repeat all our testing and imaging and so forth. They will do a quick consult and then get them into the operating room.
So yeah, you're only about a 3-hour drive?
Close to. It's actually a little longer probably, but from Iowa City, about 4 hours. But again, many of our patients are probably living not that far from Rochester, Minnesota anyway.
Right.
So.
Right. So just wanted to make sure that people understood what the service model will look like at this time, and when and if it's necessary to bring in a surgeon, then that'll happen. So we've gone through your history, we've gone through your referral systems, we've gone through your staff. What else do you do with your time when you're not in a lab or with a patient?
All right. So unfortunately, I'm a pretty boring person because besides all this stuff, the other stuff I do is pretty boring too. So I'm a journal editor for the Journal of the American Heart Association. I work with the American Heart Association on committees and all that fun stuff. So that's what I do in my spare time. Yeah, it doesn't sound too fun, huh? But it's important, and it's kind of fun for geeks like us. I do have a wonderful family, a wonderful wife, and 3 kids, and so they keep changing their ages, so I have to think.
What happens every year?
I know, it's very frustrating. So they're 10, 13, and 16 right now. So it's a great family. I don't spend enough time with them really, but whenever we can get together, we make short trips. We're big city people actually. So Pittsburgh was the smallest city we'd lived in, and it's about 2.5 million. And we're around 400,000 here in Iowa City. It's a great city. There's a lot of great cultural activities here, but it's it's a much smaller city than we generally lived in. So we do make short trips to Chicago or other large cities and do that sort of thing. And the other thing that's really important is Riverside, Iowa is about 20 miles south of us. And do you know what Riverside is? No.
I do not.
No, I'm very disappointed, but my kids also don't know. But it is the birthplace of Captain Jim Kirk. And I'm a Trekkie. So
you think? You must be. I'm sure all your fellow Trekkies really love you now for knowing that you knew that fact. Have you been to Mecca?
Have I been to Riverside?
Yes.
Well, there isn't much there right now. They have a flag apparently, so I've driven past it, but that's about it.
Okay.
There.
We expect you to start organizing. Here you go. This is a great HCMA fundraiser. We'll have, Captain Kirk Day and this little panel will bring in masses of people to celebrate.
All right, that's a plan.
That's your job. So we have a couple viewers live with us. A lot of people will be viewing this after it's been already posted on Facebook, which is why I announced the time that we're doing this, which is March 14th, and it's 11:25 Eastern time right now. So if you're going to be asking a question after that, you can post it below. We'll try to get back in touch with you. But right now, we just have a lot of hellos and a couple of your patients chiming in and saying hello. But we'll leave that on Facebook, and they can disclose themselves. That'll work. Okay. Any other questions? We're happy to handle them right now. And if not, we're going to wrap up in a few moments. I have to say that as the HCMA evolves as an organization and as our reach grows to more of our recognized centers, it's really a pleasure and an honor to be able to work with people from one program to the next. That's happened twice this year. This is a really tight community, and while a center may lose a physician or a nurse, then we pick them up someplace else and we keep them in our family. We've just moved a nurse from Connecticut to Tennessee, and one program from Baltimore to San Francisco, and you from Pittsburgh to Iowa. And we just love keeping this family growing and making sure patients with HCM have access to high volume quality care, no matter where they live in the country. So it is an ongoing mission. Any of our supporters can help us in that mission by donating or becoming a member. Oh, we do have a question. So that'll wrap up the HCMA little was a soapbox moment. Angela wants to know, how do I find out about HCM in children? So you want to talk about what pediatric services that you have?
Yes, yeah. So we do partner with our pediatric cardiology clinic as well, and we have a couple of providers that are interested in HCM. For the most part, what we do is we will refer the kids of our patients to our colleagues, Ian Law, particularly on the pediatric cardiology side. It's flexible. If necessary, we can try to arrange to have the kids seen the same day. Most of the time, we haven't had to do that very much yet, but we can try to. It can happen. So we've seen families. Most of the kids have been old enough to be seen in the adult center, but if necessary, we can certainly work with pediatric cardiology to do that as well. So we have certainly sent some of the kids of our patients to pediatrics, and vice versa. In some cases, they've seen patients, young kids with HCM, and of course, then they know that their parents need to be screened, so their parents are sent to us for their screening and potential care as well. So it works reasonably seamlessly.
I'll talk a little bit more globally. That's how this program in Iowa is going to be addressing children in HCM. I think the important thing to note, if you're not in the Iowa area, if you have a child with HCM, I would encourage you to be involved with a center of excellence in your region. If there's not one that is convenient, I would encourage you to call the HCMA office. Let us help you find some resources so that either you can work in collaboration with a larger center with your local cardiologist, or maybe we have somebody that you don't know about or isn't necessarily on our center of excellence list yet, but might be coming up. So call the office, we can give you that information. He was diagnosed 8 months ago. He's a big kid, he's 12. I was diagnosed at 12 too, so he's in good company. And we do want to make sure that kids who are diagnosed in that early adolescence phase get involved with good quality care to ensure that nothing gets missed or nothing falls through the cracks, and you have the opportunity to provide them with state-of-the-art care. So Angela, do call the office if you need some help in finding a center of excellence or somebody maybe a little bit more knowledgeable than your local cardiologist. Anything you want to add to that one, Dr. Ahmad?
No, I think that's absolutely correct. Kids probably a little bit lower risk of developing HCM at that age, but they can, and it certainly happens. And sometimes, unfortunately, there's actually 2 genetic mutations or variants running in the family, and some kids are unlucky enough to inherit 2 variants, and then they have a very severe disease. So it is important to have them assessed. And no, there is some degree of controversy or uncertainty in the community as to how soon kids should be assessed or how frequently and what age. In general, unless the family history is really very, very concerning and there's been a lot of kids with HCM or a lot of sudden deaths in the family, I would say as soon as kids are old enough to cooperate with an echocardiogram, that's probably a good time for them to get one screening. And if everything looks fine at that time, then they're probably okay to wait till about 12 years of age to get rescreened, around the time they're hitting puberty. But
I would make a slight change to that, and I've been very concerned about that number 12. Mm-hmm. It's really the onset of puberty that's going to create these physiologic changes, correct?
That's right.
So you really have to monitor your child. In certain communities, puberty starts sooner. In African American girls, for example, the age has been coming down as low as 8 years old. So you need to know your ethnicity, your family traits for when you enter puberty, and that's a really good time to start looking at your kids a little bit more. And remember, those hormone shifts start happening before you can see the visible signs of puberty. So just keep these things in mind when picking that starting point. We say age 12 or onset of puberty, and then there is some controversy over how often those screenings should be. I advocate on the side of caution, and that's a 12-month interval. Some programs will say 2 to 3 years. I've seen the window completely missed, and I've seen bad things happen when there's too long of a gap. So I'm in the 1-year evaluation, ages 12 to 25. That's where I'm most comfortable from my vantage point. There's some clinical data that, they'll argue and say, oh, we could cut it off at 23. We can start at 14. We're living in the ACA age where your children are on your health care plan until the age of 26. I think that's a pretty good marker as to when they're really adults and their bodies are fully formed, and when we can move off to every 3 to 5 years as adults if they haven't shown up. Right. Please comment. I'm on a soapbox again.
No, so I completely agree with that, and that's usually what I recommend. That once they're hitting puberty, then once a year assessment is probably the most appropriate. Assuming that there's no new symptoms or anything new that's happening. The other thing we haven't talked about is that we do have genetic testing available, and a lot of families now have identified what their genetic variant is that's causing the disease. So with that information, sometimes you can figure out, well, who's really at risk, who has inherited the mutation and who hasn't, and then you can really focus on continuing to screen individuals in the family, kids that have the mutation, and you don't have to worry as much about the individuals who have not inherited the mutation. Now, having said that, sometimes you're very, very sure about a mutation, but even though I'm a geneticist and I rely on genetic information, we can get things wrong sometimes, or there can be more than one genetic mutation in the family. So I kind of advise in most situations that even if we think we know what the genetic mutation is and somebody in the family doesn't have that, I still recommend at least one clinical screening, with history, physical exam, electrocardiogram, echocardiogram, just to make sure there's absolutely nothing that's concerning. And if they don't have the mutation that's in the family and their clinical screen is fine, then they're probably good and they don't need to keep getting screened subsequent to that.
So let's dive in while we have just a moment. And I know you have to get to a meeting for noon, so I'm not going to keep you too much longer. We have a good question here that spurs on another slight conversation. And here is exactly what Stacy posted. I can put that up here for everybody. If one parent has it, one daughter, 24, just tested negative. I think we're asking, what are the percentage of her to get it over time? So address that for us.
So that, I don't know if anybody has a clear answer. We think that most people will be developing disease by their 20s or so, and if they're negative, they're less likely to get it later, but we don't know that for certain. Part of the reason for that is that we are diagnosing people at much older ages, 50s, 60s, even 70s. Now, we don't know that they didn't have it before. It's just that that's when they came to medical attention. So Katie, who's our nurse practitioner, I had that discussion just last week. Is there a time where we can say stop screening? I don't know if anybody has a good answer to that. I would recommend that they continue to get screened, even if everything's negative, 3 to 5 years. And if the family history is not too concerning and there's not a lot of sudden deaths, maybe around 5 years, but probably just keep getting screened. Not annually anymore, but once you've hit about, as you said, 25, 26. Maybe every 3 to 5 years, or 5 years if everything's benign in the family history, to be safe. And maybe it's overkill, but given the potential negative consequences of missing something here, it's probably worth it. And of course, if you do have genetic information on top of it, then that can help guide whether your daughter would continue to need screening or not afterwards.
So going down the pathway of genetic geeky information. So I've been asked to serve on an advisory committee on the best approaches to reclassifying variants of uncertain significance. What are the impacts when we keep primarily it's variants of unknown significance, but what happens if you had a pathogenic mutation, which is now found to be either a VUS or benign? So for our non-genetic geeky friends, pathogenic is that gene definitely causes that disease. We've proved it multiple times. We know it. Variant of unknown significance means it's in a region that could be something that would cause a display of HCM, but we haven't seen it a lot and we're not sure, but the mechanisms look like they might work. And benign is, no, lots of people have this. It's not associated with disease. So we're in this conversation of lots of variants of unknown significance, and then they shift in time. How often should patients be checking in on the meaning of their variant and the understanding of the clinical implications associated?
Yeah, so that's a good question, and I don't know if there's one perfect answer. Scientific information and clinical information keeps changing quite rapidly. Often, depending on the center you're at, sometimes the counselors will go back and reinterrogate the variant and speak with the testing lab on annual visits, for example, or every couple of years. This is probably reasonable. Most of the time, we're going to rely mostly on clinical information to treat our individual patients. And for our individual patients, the significance of variant right now probably doesn't make a huge difference in clinical care. Where it really is important is for other family members to know, well, are they at risk or are they not at risk, depending on whether they have this variant that is really pathogenic or not. So I would say every couple of years is probably a reasonable interval, just because things change so rapidly. If you vary a bit from that, that time interval, that's fine. It's not like it's going to change things immediately. It's certainly not for your own care as a patient. It's really just mostly going to be to help guide what's happening in the family. And if you don't have genetic information, we recommend that family members get screened clinically anyway. So that shouldn't change regardless. So I would suggest that people don't get overly concerned about the classification and sort of have it checked every couple of months. It's not going to change things. But I do also think that, yes, you shouldn't just completely ignore it and never think about it again. Go back every couple of years. And your genetic counselor at your center may do it anyway. If not, you can ask him or her to go and reinterrogate it every couple of years.
So I like to look at life with HCM as constantly having a plan. And that's what we provide here at the HCMA. We do planning calls with people. What do you need to know to make the next decision in your life, and at what interval should you revisit that question? That's pretty much it. How often should you get assessed for sudden cardiac arrest risk? How often should you have a Holter monitor to see if you're having undetected AFib that you're not feeling? When to screen your family. So this is all part of that planning. This is on my 1 year, this is on my 3 year, this is on my 5 year. I think genetic reevaluation right now should be on that 3 to 5 year list. And you just go back and ask, anything new? The answer is probably going to be no, but you ask. Reasonable?
Yeah, I think so. There's no right answer here. Again, don't do anything like this every couple of months. It's not going to change anything for you or your family.
Just drive you nuts.
Yeah, exactly. It'll just drive you nuts. Exactly. And so every couple of years, every few years, even 3 to 5 years is totally fine. I don't think it's going to impact things one way or the other if you do it less frequently or more frequently.
Awesome. Any parting thoughts before we say goodbye to everybody?
Well, just excited that we have been able to partner with you once again for a second time, and we're looking forward to working together, both for clinical care and for further research, because being part of this network that you've established, we have a lot of great data, de-identified data that we can then use to try to improve our care for our patients and maybe understand some of what our patients are experiencing better than we can as individual centers.
Absolutely. This is a collaborative operation. And as the old adage goes, rising waters raises all ships. So we are all going to sail together, and we are going to try to raise the waters of understanding and clinical options and support for everybody with HCM and our clinical partners and our research partners. So thank you for joining us today. Thank you for being part of our ever-growing HCMA Recognized Center of Excellence family, and look forward to working with you on lots of stuff in the coming weeks and months.
Great.
Thanks, everybody, for joining us. Have a great day. Bye-bye.